Okay, so I'm going to share my screen. Just bear with me. So I'm Dr. Sathi. This is obviously the main sponsor of the event, Aid Career, who basically have brought us all together. And I'm very grateful to the work of Sumidesh and Shujidesh in pushing this forward, which is a very important area in healthcare, not just in India, but also worldwide, looking at autoimmune disease. So the talk primarily is obviously on rheumatoid arthritis, and it is a rhetorical question that is it just our perspective, or should be, as in the Aid Career Foundation and Aidathon perspective, or should there be a general perspective about it as well? So I'm a specialist in rheumatology. I'm also an internal medicine specialist as well. So the question arises is, what is arthritis in the first place? And essentially this is part education, part sort of explanation as well of what arthritis is. So essentially, it's a disease that affects the joints of the body. There are two broad types of arthritis that I, as a specialist, deal with in terms when it comes to arthritis, and they are osteoarthritis and inflammatory arthritis. And it's important to understand the difference. So, in terms of osteoarthritis, it's usually the age group affected is an older age group. In terms of the data, after the age of 45, that's when osteoarthritis generally develops, and it can be progressive. The symptoms are in the main mechanical, i.e. they affect you when you are using that particular joint. So, for example, in your hands, it can be the base of the thumb or certain joints in the hand, or it can be your shoulder, or it can be your knee or your hip, or even your ankle, depending on what damage has taken place there previously through trauma or through the aging process and physical deconditioning. So the swelling generally is hard in osteoarthritis. This differs from the conditions that we see with inflammatory arthritis. Usually it's in a younger age group. They have inflammatory symptoms, so whereby they are actually stiff in the morning, which some of you will know of relatives who've had this, and it takes them at least half an hour to an hour to get going in the morning. The discomfort eases with activity, and the joint swelling is generally soft. In terms of the activity, they'll obviously feel stiff in the morning. They'll find the symptoms will also return in the evening as well and give them problems overnight, so leading to a poor sleep-wake cycle and thus causing more problems. But generally, the joint swelling is soft. But what exactly is rheumatoid arthritis? So if you imagine, we can get autoimmune disease to any part of our body. So people, for example, can get autoimmune thyroid disease and develop hypothyroidism when they're getting older. So the thyroid regulates our metabolism, and often patients will feel cold, and feel more constipation and a bit of slowing in their cognition. So, that's an example of an autoimmune disease, but that's specific to the thyroid. In this case, this is the autoimmune disease to the lining of the joint, which is the synovium, which is the synovial cover of the joint. The arthritis itself, as you'll see later on with regard to the criteria that can be used to help with diagnosis for studies, is essentially primarily affecting the small joints of the body. So they are in the hands and the feet. They include, as already mentioned, the metacarpophalangeal joint. So these are essentially the bit of the joint where your finger joins the main body of the hand. The proximal interphalangeal joint is the next joint on from that, and obviously similar joints in the feet. So they are the metatarsalophalangeal joints, and again, the other joints as well. They can affect any joint in the body, wherever there is lining, synovial lining, as it is, as I already mentioned, an autoimmune disease to that part of the body. So a brief history of rheumatoid arthritis and what we know so far. So in terms of the human remains, they were found in modern-day Tennessee, dating back to 4,500 BC, suggested that people had RA then, and that would obviously refer to the indigenous American community. The first symptoms description, you'll be glad to know, was actually in the Indian Ayurvedic text in the Charaka Samhita in 123 AD. There's obviously some time lag, and we don't know what's happened in between, but certainly the next description we have at the moment is in 1591 by French physician Guillaume de Biellou, wrote a general text about inflammatory arthritis. And the first description of rheumatoid arthritis was in 1800 by a French physician, Dr. Augustin Jacob Landry Beauvais. The actual term rheumatoid arthritis was coined by a chap by the name of Dr. Alfred Garrod, who's one of the pillars of rheumatology in the UK. And rheumatoid actually means rheumatism. So obviously patients, when they're presented to the physicians, had rheumatism, as they do present around the world, but this is rheumatism with an arthritis. The word itself is of Greek origin. So
Dr.
before
Navtej, may I
we,
request to press the hide button because the screen is getting done. Can you press the hide button
sure.
on the screen?
Yeah, there we go.
Thank you.
Apologies. So in relation to the disease itself, one of the biggest problems we find is actually, and as I'll show you in the future slides, is epidemiology. And this is actually essentially the R&D of any disease process. If you imagine if you're running a company or you're running a business, you want to know what your customers, who your customers are, and who actually needs your product. So in the same way, epidemiology is a way of identifying who has the disease, where are they, what is the incidence, what's the prevalence, and again, once you have the good R&D, then you can identify how best to actually tackle the problem. And from an international perspective, there are 3 cases per 10,000 per annum. It's uncommon below the age of 15. Incidence rise with age, more common in females, as you find out later on why, on a 3-to-1 level. The peak female incidence is around the 40 to 60 age group. In the US, there are about at least 1.3 million people with rheumatoid arthritis. It's about 1% of the population. Sorry, that may be a mistake. Actually, probably slightly less than that. In the UK, we have about at least 400,000 patients, which is about 0.7%. And again, 20,000 new cases every year. In China, from their data, they've identified 0.2 to 0.3%. From our perspective, I've really put this paper on. Dr. Handa has done a great work in rheumatology. He's a rheumatologist based in Delhi, and he has done a lot of work in rheumatology. So he's collated a number of studies as they really speak for themselves. So 28 studies were reviewed, identified for data extraction, 7 described descriptive epidemiology RA, 40 described comorbidities and extra-articular manifestations, 9 described the functioning abilities and quality of life among patients, and 10 provided information on treatment. So there's a limit in terms of what is going on in terms of studies for such a large country as India. So the conclusion was that the review is confined to studies with small sample sizes, cross-sectional designs, and or clinical settings, and may not be representative of the entire Indian population. There is a need for more robust studies, as conclusions for the entire Indian RA population cannot be drawn from only the current observational studies. But based upon the work that Dr. Handa did, he found it was based upon the 4 studies, it ranged from 0.2 to 0.7%, based upon the American College of Rheumatology criteria for diagnosing rheumatoid arthritis. Rheumatic symptoms that were also included in the studies that were reviewed were 1.4 to 5.2% within the Indian population thus far. So in terms of coming back to that, I'll go back to the next slide. So there's actually a roll on. We have to understand, why is this the case? And maybe, is there a diagnostic delay? And certainly listening to many of the people speaking from the panel and the audience, there is an issue with diagnostic delay and perspectives, both of the physician and of the patient. So the problem we have is obviously getting people to the right doctor and to the right specialist. There's a lack. This is a study by Jain et al., my colleague of mine working in Rajasthan, in Jaipur. So lack of rationalization in terms of the symptoms. So that is an important factor. maybe thinking it's actually just one of those things. It's part of life. Signposting of symptoms, so understanding where to go when you have these problems. Lack of appropriate doctor advice, which has also been highlighted by members of the audience. Influence of and lack of education in the family. This is a big factor when it comes to actually understanding disease process, and is the big problem not just in India but also nationally and internationally as well. Following traditional beliefs, so believing perhaps in taking certain herbs and remedies to treat the problem rather than actually tackling the problem early to try and get an early diagnosis, early treatment, and preventing progression of disease, and possibly also getting the patient to remission and at some stage off the drugs. Poor referral. So again, there's a lack of knowledge within in the primary care physician population. And this is not just a problem both in India, but also a problem here in the UK as well. I'll give you an example. 25 to 30% of patients in the GP research from the GP research database were actually had musculoskeletal problems, so rheumatological and orthopedic. Yet when you look at the training that doctors have, only a small percentage have had any formal training in rheumatology or orthopedics. And that refers not just to primary care physicians, but a whole variety of doctors. And also the lack of rheumatologists. So rheumatology has been the sort of poor cousin of specialities, both nationally and internationally. We've seen certainly in Europe and North America, and Australia, and New Zealand, there's been a big drive in rheumatology and the number of rheumatologists being trained, and obviously a big drive in how to get an early diagnosis and early treatment, which has had a good degree of impact, certainly in rheumatoid arthritis, but less so in other autoimmune diseases like SLE and psoriatic arthritis and seronegative spondyloarthritis. In terms of risk factors, genes are a factor which I'll talk about in a moment. Female, with regard to some factors that may explain why it is more common in females, there is a hormonal change theory, which is probably not a theory, it's probably a fact, really. So it can happen post-pregnancy. So when patient is carrying a baby, it's like carrying an extra body that has a different kind of immune system. And so the patient's immune system has to sort of manage that as being a host to that baby. The menopause also brings a change with the hormonal changes it brings as well, and again leads to an increase in the risk of autoimmune disease, making us think that perhaps estrogen has that positive effect of keeping autoimmune disease at bay. In terms of if you have a family history, there's a 3 to 9-fold increase in chances of you yourself getting it. With regard to twins, if one has it, there's a 15% chance that the other one will get it, which is actually 30 times the actual risk. Physical and emotional stress, something that is very hard to quantify, but something that actually is a big factor in patients. And when you speak to them and ask these questions, that will crop up. Smoking is another trigger, which probably goes in line with physical and emotional stress. A good reason why patients smoke is a combination of factors, including addiction, as well as stress. The factor involved in smoking involves taking deep breaths. And you've got to bear that in mind when you are stressed, you do take deep breaths. And certainly some of the exercise for reducing stress do involve deep breathing. The sad thing with smoking is that you're inhaling smoke, which perhaps is not as good as perhaps inhaling just plain air. And obesity, which is a big problem, not probably coming up nationally, maybe in certain metropolises, in certain cities around India, but also nationally and internationally, is obesity. So that is a big problem as well, and a big factor in causing this problem. As we know, people who are obese, if you don't know already, have high levels of inflammation in their body. From a genetics and pathophysiology point of view, these are just a few of the genes that I've highlighted. This article can be found online by Dedmon et al. It's in the Rheumatology Journal. The reference is there. If you just Google Dedmon et al. Or Dedmon actually and genetics, the article will come up and it is free to access. So essentially, there are a number of genes that are involved. HLA-DRB1 is the main one that is transethnic, including Indians. You'd be interested to know that there is a study has been done in Pondicherry, and it's shown in the 2 million population that they have this genetic problem with regard to a risk factor for rheumatoid arthritis. Also in the African American and Indigenous American populations. In specific regard to European populations, the certain genes other genes have been identified, which is PTPN22, STAT4 and TRAF1-C5. Another one is PAD14, which is again transethnic, including Indians and African Americans. Han Chinese have identified DPP4. In the Japanese population, HLA-DPB1. Another one in the European population, RAD51B. So I strongly advise you to look at that article. It's a very good article. There's another chap who's also written on it as well. I forget his name, but certainly have a look at that, please, as a way of understanding the genetic risk behind getting RA. So this is an indication of the inflammatory response that takes place. And you have essentially the dendritic cell that presents to the CD4 plus cell that leads to the upregulation of the whole inflammatory process and the autoimmune process. So obviously that is the to the left, you'll see the dendritic cell and CD4 plus cell, and that's where things kick off, essentially, and then, you know, the autoimmune process starts. And that's why you'll see, if you look at some of the cytokines involved, we use anti-TNF, which was primarily the first drug that came out, or biologic drug that came out after the the synthetic ones, which were methotrexate previously and sulfasalazine. Now biologic drugs are available, and essentially TNF was one of the first ones to use to treat this disease process from a biological point of view, as patients ran out of options with using synthetic disease-modifying anti-rheumatic drugs. Also, IL-6 has been shown to be helpful, and there's two drugs out there. One's called Kevzara, which is salimumab, and also tocilizumab for tackling IL-6, and they've been shown to be beneficial in treating patients with RA who failed synthetic disease-modifying anti-rheumatic drugs. But as you can see from the actual process how the inflammatory response gets upregulated, and how it causes damage to the lining of the joint, and how it can also have a knock-on effect on other parts of the body as well. As you increase your inflammation in your body, but increased risk of cardiovascular disease and also osteoporosis. So the symptoms primarily, I've already mentioned already, are early morning stiffness lasting at least 30 minutes in the morning, and that's where we as rheumatologists get very interested. It comes on at rest. It can affect your sleep. There are swollen joints that are soft swelling as opposed to hard swelling. The main joints I've already mentioned have been the small joints, mainly the metacarpophalangeal joints, metatarsophalangeal joints of the feet, and the proximal phalangeal joints. Patients will, with regard to the feet, feel as though they're walking on pebbles. There's the signs. To the left is a patient with slightly more acute swelling. You can see some of the joints are swollen. These are the proximal phalangeal joints. This is the first joint after the finger sort of interdigitates with the main body of the hand. Do the metacarpophalangeal joints set at the base, and then the proximal phalangeal joint. And you can see on the left, basically, a patient who's got perhaps a more early form of inflammatory arthritis of rheumatoid type. And then to the right, you have a patient who has developed these joint deformities, which we call, where the joint subluxates, essentially, they lose their function in their hands. And that's due to the imbalance that the swollen joint creates and affects the ligaments and tendons in the surrounding area that causes the joints to become that way. And the goal of treating these patients is early diagnosis, early treatment, and the aim is to maintain function as much as possible. So the aid to diagnosis is actually taking a good history and examination. This comes to the fundamentals of medicine. And obviously, if you, as a junior doctor, some of you are in the audience or if you know people who have the problems, is taking a good history of the patient to find out where the problem is, how long they've had it for, did it come on gradually, did it come on suddenly, do they feel stiff, is it getting worse with activity or better with activity? And that gives you an idea generally on whether this is a mechanical problem or an inflammatory problem. Inflammatory markers, such as we use the erythrocyte sedimentation rate, I know they can use plasma viscosity and also C-reactive protein, give us an idea of how much inflammation is going on with the body. That could be adding into the diagnosis of the patient. So primarily it's history and examination that is the bedrock of finding out what's going on with the patient. Everything else adds in to confirm your diagnosis. So we have inflammatory markers, platelets, they can be raised in patients with inflammation. Also, the liver function test can become abnormal in relation to the GGT and the alkaline phosphatase levels, because of those get affected when levels of inflammation are high in the body. And obviously a positive rheumatoid factor, an anti-CCP, otherwise known as ACPA, are factors that also highlight that this could be more likely to be a rheumatoid arthritis. With regard to anti-CCP, it's worth noting that this can be present before, during, and after the diagnosis of rheumatoid arthritis. It may not be there initially, but it may present later on after the diagnosis itself. And also, if you pick it up before in general screening tests, you need to keep an eye on these patients over the next few years before to see when, if and when they do develop problems. In terms of radiology, this is an example of the x-rays that we don't really want to see, which is essentially a patient with advanced disease. You can see, as you see in the previous picture, where the patient had subluxation of the joints, where the joints had gone out to the side. You can almost see this on the x-ray here, showing a similar sort of picture where the joint is quite damaged and the joints are not in normal function. To the right now, we have an ultrasound image showing evidence of inflammation in the joint, with some edema in the synovial lining, and also evidence of the flare sign, which is increased vascularity around the joint, which can occur in people with rheumatoid arthritis, showing the level of inflammation going on. And this ultrasound is being increasingly used now to get early diagnosis of patients, because sometimes patients can present with symptoms, have joint tenderness, but nothing overt to suggest a swollen joint. But ultrasound is can be a very sensitive test to pick this up. So just referring to the criteria that's used primarily in studies, this gives you an indication of where the bias is. So it is primarily towards the small joints of the hand, small joints generally, which is the hands and feet. In terms of scoring, a score of 6 out of 10 is needed for classification of a patient as having definite RA for a clinical study. So these, as you can see in joint involvement, the main score goes to those with small joint involvement, at least 4 to 10, and obviously 10 joints, of which at least one is a small joint. And you'll find more often than not, it will be the small joints off the hands and feet that are affected initially. Positivity for rheumatoid factor and ACPA are important in respect of adding to the clinical picture, as is raised inflammatory markers, and obviously disease duration. So if it's been going on for over 6 weeks, you are concerned. So there are instances where there can be viral causes, such as with parvovirus, that can cause a clinical picture suggestive of a rheumatoid pattern, but resolves within 6 weeks. So in terms of extraarticular features that have been found from the literature generally, there's a thing called atlantoaxial subluxation. And what that means is these are generally patients, again, with advanced disease. We're seeing less of this now because of better treatments here in the UK. But essentially, if you imagine, I should have put the anatomy of that on the side, but this is in the cervical spine. So at the top of your neck, there's a area which connects in with the skull and everything else. And that can be diseased because there's synovial tissue there, and cause problems with, basically, when you move your neck, it can cause problems with spinal instability. Interstitial lung disease, essentially an autoimmune disease of the lungs, which can occur due to a variety of diseases, autoimmune diseases, which includes rheumatoid arthritis. And that involves inflammation in the lungs that can cause scarring. Usually the lower lobes of the lungs are affected. Cardiovascular disease, I've already mentioned already. So there's a higher risk of cardiovascular disease, and so basically heart attacks and strokes in this patient group, especially if they are not treated. Inflammation of the blood vessels leading on from that can cause problems further down if not treated. Again, we see much less of this now with early treatment, early diagnosis and treatment, and also with the advanced therapies that we have. Patient can get neuropathies, which essentially are pathology affecting the nerves, where they get damage to the peripheral nerves because of inflammation, primarily caused by inflammation of the blood vessels supplying them. Patients can also have chronic pain issues due to the disease process, and also mental health issues. So it's not surprising that a significant number can become anxious and depressed because of the effect on their physical and mental well-being, and primarily their ability to work and be productive in society. From an Indian perspective, Handa et al. Again extrapolated data from the studies he looked at. He found that 25% had anxiety, 33% subclinical atherosclerosis, 15% depression, 22% osteoporosis, 11 to 18% sicker symptoms. So sicker symptoms essentially means having a dry eyes and dry mouth. We have glands in those areas that have immune tissue, which is why they secrete a liquid that is also protective, also for the eye and for the mouth as well. And they can get affected by the disease process. Patients can develop things called rheumatoid nodules that can occur in any part of the body, primarily around the hands and elbows, which are, again, sort of granulomatous, so types of granulomas that accumulate in various parts of the body. Patients can feel quite exhausted with the disease process, and 1 to 9% can get interstitial lung disease, certainly from the Indian population data. A significant number have anemia, which is basically caused by the inflammation causing suppression on the bone marrow and causing dysregulation of the normal production of your blood count, your hemoglobin. A good number will have dyslipidemia, which is essentially effects on your lipids and your cholesterol, which again feeds into the effects on increasing your risk of cardiovascular and cerebrovascular disease. 15% of fibromyalgia. Fibromyalgia is certainly a term that's bandied around a lot, not just in the UK, probably in India maybe, but also in the UK, quite a bit too easily. And fibromyalgia, I will stress to you, is actually a diagnosis of exclusion. And more often than not, patients have fibromyalgia secondary to another disease process, which is as illustrated here. 36% found to have a raised white cell count, 40% thrombocytosis, I've already mentioned a raised platelet count, and more concerning and more interesting is that 26% have TB, which has implications for further treatment with this population. So, when we see patients, we screen these patients with a chest X-ray, as well as doing baseline blood tests before starting on them on disease-modifying anti-rheumatic drugs. And obviously, if we pick up TB, we initiate treatment and can start disease-modifying drugs at the same time. The treatment our goal is to, obviously, part of treatment is actually to diagnose the patient early. And by diagnosing the patient early, we have a window of opportunity to get in early and treat them early and get them better, and to therefore induce remission and thus prevent joint damage and disability and all the pains and all the problems it causes, not just for the person, but also for their families and also for the environment as well they're in. So the primary drugs we use are non-biologic synthetic disease-modifying anti-rheumatic drugs. These are our first-line drugs, which I'll go through in a moment. Biologic disease-modifying anti-rheumatic drugs and steroids. So essentially, methotrexate is the drug that's used most, both in the UK and you'd be interested to know in India as well. It's a dihydrofolate reductase inhibitor. It obviously affects in terms of cell division and white cell, and will have knock-on effect on white cell production, which are the cells involved, the T cells involved in actually attacking the joint and causing more problems. And obviously, it slows their migration to the joint and therefore leading to reduced joint symptoms. Sulfasalazine is another drug that we use, and there's two aspects to it. It's the 5-acetylsalicylic acid moiety, which gets excreted in the feces, and also sulfapyridine. So sulfapyridine has the anti-inflammatory effect. The flunomide works by blocking pyrimidine synthesis, and again, that leads into reducing the number of cells that are around in terms of white cells. Oral gold affects lymphocyte function. Iron gold affects macrophage and B cell function. Prednisolone has anti-inflammatory effects, as we already know, by blocking cytokine production in the cell wall when the cell wall gets damaged. And hydroxychloroquine inhibits stimulation of toll-like receptors of plasmacytoid dendritic cells. So in terms of biologic DMARDs, I've already illustrated a few things in the previous slides. So we have anti-TNF, which is the drug that we use in the main, and there are a range of drugs out there at the moment, including adalimumab, etanercept, certolizumab, golimumab, and infliximab. Infliximab was really the first one out there, which is an infusion, followed by etanercept and adalimumab. We also have B-cell blockers, essentially, that have an anti-CD20 effect, which affects the patients with their B cells. So B cells are essentially, so just to broadly understand this, there are T cells and B cells. So T cells are your first line of immune defense. That's your innate immunity. The B cells are what called adaptive immunity. So they're in your bone marrow and in your lymphoid tissue, in your lymph nodes. And that's where antibodies get produced. So obviously, many years ago, they had a debate about the T cell versus B cell theory, and really it all works hand in hand. So we have a biologic DMARD known as rituximab that's being used to tackle this problem, and it's shown to be greatly beneficial in downgrading the autoimmune response in patients with rheumatoid arthritis. Interleukin-6 blockers were, again, another blockbuster drug many years ago. They include tocilizumab and salimab. T-cell co-stimulator receptor blockers, which is abatacept. Again, it's suitable in certain patient types, has reasonably good results. And the JAK inhibitors, such as baricitinib. So it's interesting, I was looking before the talk just to double check my understanding of what JAK inhibitors were, and it's just another kinase. So there are a few JAK inhibitors out there. Baricitinib is one of them. There are quite a few others as well, which are the new kids on the block in treating autoimmune disease, including rheumatoid arthritis as well. In terms of usage of DMARD, again, this is work from Handa et al. So methotrexate is used from the population he assessed, 73% of patients. Steroids, quite sadly, is being used by 13 to 50%, 13 to 57% of patients. Now, steroids, I should highlight, as I'm sure you're aware, if not, I will tell you now, is that the problem with steroids is that we use it in the UK now just for short-term use. So or unless we've got no other option with the patient, and they're usually older patients with many comorbidities. So steroids have the negative effect on the patient, both in terms of affecting their glucose control, increasing the risk of developing diabetes, or worsening their existing diabetes, affecting their hypertension control, the high blood pressure control, or causing hypertension, affecting their body fat distribution, and patients that can become more obese, and also have a knock-on effect, increasing risk of heart attacks and strokes as well. And also they thin the skin and also can cause osteoporosis as well. So steroids is something we try and avoid really. And it's disappointing to see that actually at the moment there is a good amount being used within the Indian population. Sulfasalazine is used by 11%, gold IM by 11%, chloroquine by 9%, azathioprine 7%, D-penicillamine 7%. Cyclophosphamide, was interesting to read, was 4%, which is quite a strong drug, but still effective, and IVIG as well, 2%. So to assess for a response, we have a number of measures for this, but traditionally use the swollen and tender joint count. But in the last sort of 15, 20 years, a number of disease activity scores have been developed, but primarily we use the DAS score, which in this case is the DAS-28 score, and we assess the patient clinically by assessing their tender joint count, their swollen joint count, their levels of inflammation, which is their erythrocyte sedimentation rate, otherwise known as ESR, and their C-reactive protein levels as well, and also do a patient visual analog scale to see how they are in themselves in terms of how bad they feel, despite being, apart from arthritis, how they're feeling themselves generally. And that goes into a calculation that works out how active the disease is in that patient. So having sort of treated the patient, early diagnosis, got the treatments in, and they're moving through on disease-modifying drugs, depending on how aggressive they are with the disease process, they may end up on the biologic drugs, as already mentioned. So some of the screenings we do include essentially for TB, viral hepatitis, HIV, and anti-nuclear antibody in this rheumatoid population. So obviously, if we pick up any of these, then obviously the patient needs to have some of the therapy before being considered for the biologic therapy itself. In terms of the drug success rate, so non-biologic DMARDs are synthetic, about 45 to 50%, and biologic DMARDs have a success rate about 60 to 70%. And that's as a drug itself. In terms of measuring success, we have what's called the ACR 20, 50, and 70 that gives an indication of how much better they are in terms of the DAS scores and generally in themselves compared to how they're presented. So 20, as you can understand, is 20%, 50, 50%, and 70, 70%. In terms of patients now, they've had obviously the disease process and they may have got some joint damage and have difficulty doing activities of daily living, such as holding a spoon, holding a knife, doing chores in the kitchen, opening the door. There are aids that can be provided for these patients. And the example on the right of the picture, these have been 3D printed for patients. So they can get aids for bottles and cans, opening bottles and cans and doors, aids to help with getting clothes on, aids for keeping hands functional, and also aids for footwear as well, because they can get damage to feet, which is probably underreported and not really looked at as much as the hands. and also stop smoking apps, because as well as smoking being a risk factor for developing RA, it's also a factor for keeping it more active as well. And certainly in my patient group, when they do stop smoking, the disease activity does actually improve, and that has been shown. So stop smoking apps would be helpful for these patients, or alternative things. So I sometimes suggest to my patients try the e-cigarette as a way of putting less stuff into the lungs that's going to inflame it. So if you imagine why you think of smoking causing inflammation, our immune system deals with the whole body. And so we have our lungs, we have our joints, we have various other parts of the body. So when you have a rheumatoid patient, or patient with any kind of autoimmune joint disease, they'll have inflammation in their joints. Their joints are on fire. So the immune system is geared up to trying to tackle that problem. And not even tackle it, actually make it worse, because obviously unless you put anti-inflammatory products in, it will continue. So if you imagine inflaming your lungs, then you're adding another fire into that process. And therefore this immune system regulates again and makes the inflammation generally worse in the whole body. So in terms of tech solutions that we talked about, you may have read about the vagus nerve stimulator that was done by the group in Amsterdam. So essentially, it's an implanted nerve stimulator that affects on the vagus nerve, that has an effect on reducing, has been shown to reduce inflammation in rheumatoid arthritis and getting people into remission. And this has a knock-on effect on the spleen, which leads to an effect on the immune system, as the spleen is a part of the immune system. So what about dietary effects? And something that certainly Deirdre mentioned to me, to see whether there are any aspects of diet that we can do to try that will help with the disease process. So this is a book that's been edited by our colleagues in Chandigarh and Ludhiana. This is a book that is internationally available, and I have a copy myself, and looking at probiotic research in therapeutics. And obviously we also talk about how, for example, fermented yogurt is quite good for you. And so in one of the chapters there, it's been shown essentially that Lactobacillus rhamnosus GG had no difference, but the bacillus coagulans reduced the inflammation markers. Lactobacillus rhamnosus GR1 and Lactobacillus reuteri RC14 were shown to give a mild improvement to patients with rheumatoid arthritis. And Lactobacillus KCI01 had some improvement in the patients. So are there any adjuvant anti-inflammatory diet? So, we all know as we were growing up that we were advised that, have healthy is quite good anti-inflammatory. Obviously, more recently, I had a patient who was using bay leaves, interestingly. So she had actually put these bay leaves in oil and was making a paste out of it, actually rubbing on her joints, which wasn't a great idea, because I wanted to try and diagnose the patient, so I had to get the ultrasound done. But she was finding it very helpful for her joints. Chili and curcumin would be helpful as well. Antioxidant foods, such as with vitamins A, C, E, and selenium, have been shown to be some benefit. And having generally a wholesome diet with whole grains, beans, nuts, and dal. Flavonoids have been found to be useful as well, with berries and grapes, broccoli, soy, and dark chocolate. With regard to broccoli and dark chocolate, they really work by having an anti-inflammatory effect on the bowel, which brings into focus the actual microbiome as well. So in terms of research on diet, Dr. Chopra is somebody who's done a lot of work on RA and rheumatology, both in India and in Asia as a whole, working in conjunction with the WHO. And this study was looking at 141 symptomatic RA patients against 165 healthy unrelated controls. And they found, interestingly, in the patients who had RA, there's a dietary deficiency of protein, calcium, and potassium, which is greater in women. 40% were reported to be vegetarian, but they, interestingly, had better function and less pain, but it wasn't statistically significant. Those patients who reported dietary restriction, ingestion of nightshade vegetables such as aubergine, or followed Ayurvedic advice, had more active RA. So that brings an end to the talk. I wish to give my acknowledgement to Simidesh and Sujidеш Das of the Aid Career Foundation, who have really driven this, to Dr. Dheeraj Kumar Mahajan, who has been the catalyst for me being in this, and to IIT Roper for being a hub of this important look at this disease area. And now open to the floor for questions.
Right. Greeting, Dr. Navtej. That was a great insight into the rheumatoid arthritis. So moving on to the question, I just have a query regarding a particular therapy that I came across while working on paper back in 2020, co-linking COVID-19 and dexamethasone. So there was this particular therapy that I came across, and I do understand that, like you mentioned in the presentation, that usage of steroid is something which is frowned upon. But this particular therapy makes use of liposteroid, which is basically using lipid emulsions containing dexamethasone. And they seem to be having, they are usually uptaken by the phagocytes, and they get retained in the macrophages pretty well. When I dig more into it, I came across that it has been extensively used in Japan, but there is no word, at least on the internet, about its usage in India. So I just have a question, like, is this therapy being particularly used in the UK context? And if not, do you believe it can be a good research topic to look over and integrate it with the Indian chapter?
So I think, thank you for that question. It's a very interesting question. All I can say essentially in relation to steroids, it's probably worthwhile looking at to see what patients are being treated, but it's also we have to get the epidemiology right. So obviously, as you know, you've seen from the work from Handa et al., we
Right.
don't have many big studies out there that can identify the size of the problem itself in terms of what people are being prescribed, how common the disease process is as well. So it's probably certainly worthwhile looking at, certainly as a review
Right.
paper primarily, to look at what's going on thus far and what the effects are clinically on those patients. So yes, it does have an anti-inflammatory effect. It's a wonder drug in many ways, but it's not something you try and use long term. We try and get patients off this drug as soon as possible. So I'll give these
Right.
patients bridging therapy, which is for about 3 to 4 weeks, while they're getting bedded in with the disease modifying drug, the synthetic one like methotrexate, before we wean them off that. And we only use it for people with flares or when we're trying to bridge again to another therapy itself as well. So, we use it very sparingly. We also use it in joint injections as well. So again, my suggestion to you would be to actually do a review article to have a look at this area in itself,
Thank
and
you.
also
Thank you.
see what
I'll
else has been
take.
published as a review article as well. I'm happy to liaise with you on that afterwards.
Sure, sir. I'll take that into account. Thank you so much.
Yeah, Aditi.
Good evening, one and all present in here. So my question regarding this was, as RA is an autoimmune condition, and once the damage is done, it's not probably feasible to reverse that. So in Indian context, like for prevention, like what are the few of the giveaway signs that maybe it is related to RA in general population, so that they can look out for the things, few markers.
So in answer to your first point, actually, if we get in early with the disease process, we can actually reverse the damage. So that's the answer to the first point you've made. So early diagnosis is important. In relation to your second question, I think it's generally for arthritis generally is that identifying has the patient got joint pain, and they may not actually complain of it. People perhaps readily complain of having chest pain because they're worried about getting a heart attack, or abdominal pain and having GI disturbance. But joint pain is probably less spoken of, perhaps. I don't know why. There may be some cultural issues there. But certainly, obviously, if you observe people walking around in discomfort, so first is observation, seeing what's going on around you, observing the other person. Second thing is obviously asking the person, are they having any joint problems? Third question is basically if they're having joint problems, is it worse when they use their joint, or does it get better when they use their joint? And are they getting problems overnight as well? So those are some of the sort of flags you can flag up to see what's going on with this patient group, to see whether there are any problems. They're obviously observing the patient as well and seeing whether actually any swollen joints in a particular area as well, and if they're hard swelling or soft swelling. So I think just keep it simple, really. Have you got joint pain? So observing it, the answer is yes or no. If it's yes, then which joints are affected? Number two. And number three, does it get better or worse with activity? I think those are three simple questions to actually ask the patient when you are looking out for people with joint problems. And then you start to go for a syndromic approach to see, right, okay, you probably need to see somebody about this and get this looked at to see whether this is actually of any concern or not. So that's probably a quick and easy way. We have a system here now, for example, in the UK for strokes called the FAST system, which looks at basically looking at the face, arm, and leg and other things as well, and speech as well, to see whether the patient is having a stroke or not. So, that's an example of an acute diagnosis, whereas obviously this is more of a chronic diagnosis. But anyway, that hopefully will be a system that will help you. Does that answer your question, Diti?
Yes, sir. Thank you.
So thank you, Doc, for a very interesting and insightful presentation. I think some of the pictures that you showed there reminded us of Dad, because I guess we have seen that thing. I think Sujitesh has seen it even closer because I was at the university at that point in time. But towards the end, I think the picture that you showed at the right is actually representative of what happens if you don't get the treatment, and more so the pressure on the nerves leading to the neuropathy disturbances, and then of course the collapse of the blood vessels as the disease more gets moved into the endo arthritis and so on. So that's like kind of the thing. So one of the questions, like the new modern way of looking at nutrition as a I would say as an enabler to relieve the pain and so on. So we used to hear mom saying that, okay, if you take this food, then maybe it would lessen the pain, and if you take this, then it has got little of fiber. Of course, she did it purely as the grandmother's tales, because there's nothing on the subject right now. So do you see that with the Indian cuisine and there are so many wonderful chefs in India, both on the vegetarian side and with the other forms of food that is there. Do you see that there is some sort of a merit in reaching out, looking into the old literature, looking into the old systems of how we used to, uh, nourish our bodies, if you may say? Do you see that body of literature also coming up?
I think what needs to happen, essentially, what we have essentially is Ayurvedic medicines or medicine prior to the advent of clinical studies has been empirical, based upon experience of that physician and collating that information to that organizational memory within Ayurvedic medicine to say, well, this is what's really going on with this patient group. This is what we've noticed. This works and this doesn't work. This causes this. This causes that. You are this kind of personality. So this is the issue here as well, which is pretty much the sort of backbone of how Ayurvedic medicine was practiced, which is very holistic. So we've now moved to the molecular stage, and really we need to really validate those diets to see if anything is of benefit. And Chopra's group has done that quite well, although in a small group, to see what's really going on here. And I'll read. So Jay Prakash has just posed this question. We'll have a look at the moment. So I think what's needed essentially is to really look critically at what is being said by our colleagues in Ayurvedic medicine. Look at the historical diet, because you've got to bear in mind it's also a financial factor as well, because paying for medical therapy or medical attention is not cheap in India. In the UK we have the National Health Service, born out of the riches of empire. So we have essentially in India the problem is actually cost.
Yeah.
So that is the primary issue. So that's why we go to those things of diet, which are cost effective, cheaper, easier. Try this will help. Try like the Udrak and the whole these out there that have a natural plant steroids that have beneficial effects in reducing inflammation as well. So I think what we have is Ayurvedic medicine has come on with its holistic approach and using all nature's herbs. And we have the molecular approach, which has been basically using science to actually see what's really going on and tackling things thoroughly in terms of the molecular level. And we need to really fuse those together somehow to see what is really going on and really going through that scientific rigor, because that's what drove Ayurvedic medicine originally, was some degree of scientific rigor, without the studies. And essentially so come back to, so it says the scientific rigor. So that's what we need to do is push that scientific rigor in India, in South Asia. That's what's necessary to actually take things forward. Get people, educate people, get them to think, look at things rationally. Look objectively. Move forward in that line of thinking. Yes, there is a holistic approach, but we have to temper that with rationality as well. In terms of what this is how it's meant to be. Well, yes, there is that, and also rationally, actually, that action led to that action led to that action, and that's probably the reason why you are where you are.
Yeah.
So your father, if you don't want to talk about your father, you advised me he was a smoker, and he had a very stressful job as well. So those are two factors that have played a role in probably triggering his risk of getting RA. It probably was genetically predisposed. This is an immunogenetic disease, essentially. So that fusion between the immune system and your genes, thrown in with the whole stress issue, you'll find actually that's what's triggered things. And obviously, depending how stressful the job is, his joint pains were worse, his stiffness was worse, his joints are more swollen. The more as a result of the stress, he smoked, and with that, with smoking, his things got worse as well. So there are a lot of things that we can modulate in terms of lifestyle to try and reduce the risk of developing autoimmune disease, and if you have it, try and reduce the risk of progression as well, and feeling more pain and stiffness, and having a general, it's kind of a changing lifestyle really, and how you manage yourself. If you imagine people with disabilities, I see them on LinkedIn. When I've been to India as well, how these guys who with disabilities adapt to their situation, because the key is survival. There is no social security system there to help these guys survive. So these guys have to survive. So they have to say, right, I'm making use of the rest of my body, which I have 90% of, to actually go out and make a living, whether it be running a stall, giving you tea, whatever it is. I'm actually standing on my own 2 feet and actually getting out there. And that's something to be admired. Also, and to be appreciated, how to overcome disability. Don't just sit there saying, oh, I've got this pain, I can't do this, I'm feeling really low, I can't go out, I can't play cricket, or I can't go and see my friends. You've got to have these sort of stories there, because they really will help people focus their mind, saying, actually, I can actually do this, and I am going to do this. We do know that being active helps. Physical activity helps to a degree. It releases your local endorphins, and that has an anti-inflammatory effect as well. So we know all these things. So it's a combination of factors that really go in to actually treating the disease. So the drug is there. So that's the biomedical approach, the drug. You take this drug, you'll be better. We know from drug studies, as we've seen here, 20 to 50% of patients will get better with that drug. Yes? We also know from placebo studies that 20 to 50% also get better as well. So merging those together, the molecular approach and the placebo approach, in terms of getting the patient to believe in the drug, believe in getting better, believe in getting there, that is the key to actually, improving the overall well-being of this patient group. But going back again, the key is early diagnosis, obviously, and getting the treatment. But anyway, I hope that's
thanks, Doc.
In a roundabout way.
Thank you.
So I think Gaurav has given us a question about the vagus nerve stimulator. So that's specifically direct to the vagus nerve, and that on stimulating the vagus nerve, it has effects both on the heart and other parts of the body. It has also been shown to be beneficial in people with epilepsy as well, in reducing the frequency of epilepsy as well, which indicates how much stress plays a role. You imagine the vagus nerve, it is meant to be a very calming nerve, reduces your heart rate, reduces your blood pressure. We deep breathe, it does the same thing as well. So you go to the toilet, you go there, your vagus nerve is activated then, to relax everything down. So this is actually using a physical stimulator into patients to actually reduce the disease process, and it's quite an insight into how the nervous system has interplays with our immune system. And therefore, if you think back further, you think, well, how much stress then plays a role in triggering the immune problem and also then exacerbating it as well. So maybe a stress reduction app would be helpful. How to reduce your stress. So that would be an option. Barbara Ramdev's doing a lot of that, isn't he? Okay, any other questions from the panel or anybody else? Please feel free to ask. This is your opportunity to learn. Don't feel as though you can't ask. Don't sit quietly. No, sir, and you push now. Ask. This is a two-way process.
Vijay has raised his hand. Vijay, over to you.
Go ahead, Vijay.
Yes, sir. Sir, I want more clarity on the testing procedure of basically we test a CCP for some testings. As a computer science engineer, we have I have a hypothetical idea so that if we focus on testing facilities, if it is good enough accurate, then we make a AI algorithm to predict it. On the basis of their activities like CCP or anti-CCP.
Sorry, so repeat that question again, please. Sorry again. Sorry, Vijay. So we want to develop an algorithm based upon predictive value of anti-CCP, is that right?
Sir, actually my question is I want more clarity on the testing procedure for diagnose the rheumatoid arthritis. Like which test is accurately said that a person is having rheumatoid arthritis?
Right, I'm with you now. Okay, so there is actually no one magic test that gives you a diagnosis of rheumatoid arthritis. I think that's important to understand. What you have to understand is that this, this is a clinical disease. You cannot just diagnose it in the blood test. You have to take a good history and examination. So seeing a specialist in this area will be helpful, or a general physician who has a knowledge of rheumatic diseases, a reasonable knowledge, to actually assess the patient in the first place. Upon doing a clinical assessment, then you do the test to actually ascertain whether there's any support for your hypothesis or your diagnosis that the patient has an inflammatory arthritis. And CCP basically adds strong information, and as there's rheumatoid factor, strong evidence that to support your diagnosis, as does the patient's history, and also, if you can get an ultrasound done as well to see the degree of inflammation going on, which adds to the further information on the diagnosis. If you think about it, patients with cardiovascular problems, for example, heart failure, don't just have an ECG, but they also have a scan of the heart as well. So it's not bad practice if you can afford it to get the ultrasound scan of the joint done as well. But obviously, from an Indian context, the issue is that cost is an issue. So we need to look at low-tech solutions, which is where X-rays come in, which is something we've used. We've used many years ago for diagnosis, and now we just use to assess for any objective joint damage, which is cheaper than using ultrasound or MRI. So there's no one test that actually tells you this has got patient's got rheumatoid arthritis. All these tests do essentially is to add further evidence to your clinical diagnosis. Does that answer your question?
Okay. Okay.
Okay.
Hello. Hello. Dr. Dheeraj, can I ask one question? This is Naveen.
Yes, sir. Yes, sir.
So, Dr. Nav, it's really a wonderful talk. I am listening you from the starting. Again, here in IIT Ropar, we have a very close collaboration with PGI, and we work on arthritis, particularly osteoarthritis. And we have about, I think, 100 patient data, even the samples with us. Here I am again a learner. So we are investigating more on the engineering side, that how this the mechanics happening, how the collagen or the protein get distorted or damaged. We are studying this. But my simple question to you, that people say that, or the clinicians say that protein-rich diet is also contributing. I think my previous has asked this question same about the diet. So is it the protein is also contributing in this?
Well, it's a good question actually, but I think from the work done by Chopra and his group, they've shown essentially that. But then this is the problem is the Indian context is that there is an issue with nutrition in the South Asian population, particularly in the Indian population generally. There are a number of deficiencies in that population, both as mentioned already about potassium and also about in regard to protein deficiency as well in the diet as well. obviously we've seen that vegetarian diet can lead to less problems. Having a high protein diet, potentially yes, because it depends, they aren't very, it probably causes more oxidative stress potentially, depending on which protein you're eating, particularly meat. Other proteins like dal, I'm not entirely convinced by, but certainly, the meat in terms of particularly red meat is certainly, there's high oxidative stress to the body with that diet. So certainly, I think it'd be worthwhile looking at the dietary aspects of patients with RA or even OA and seeing whether it's a factor and whether there actually are any noted features that this particular patient group have this particular diet and this particular patient group have this particular diet. Now, in terms of actually proving it, that needs a body of research to be done. We need to look at that because obviously we can talk about these things saying, well, having this diet is bad for you, but is it really? What's the evidence? And that's the whole idea behind, this talk, this whole, all of us getting together to actually critically look at this and saying, is that a factor? So in relation to protein-rich diets, we know it can cause more oxidative stress to the body. There are not many antioxidants in meat generally, as there are in the bit more those found in the vegetarian diet. So, but it needs evidence to prove it. So that's what's necessary. Does that answer your question, sir?
Yeah. That's my question. Thank you. Thanks. Just one simple request to all the participants that please come together here in IIT Roped and PGI. We are working a lot in this area. Those who are interested, please contact us. Either Dr. Dheeraj can convey this message that we are looking for good, particularly the engineers, if they are interested in this area. We are definitely very excited because in our country, that's a major issue that engineers are allergic with the bio area, and biologists or doctors are allergic to engineers. So there is a lot of depth for the engineers as well to work in this area. You see, I am working from 8-9 years now in this area, and we are getting so much, every day I'm getting so much depth that I am thinking that my life is not enough to even understand the basic thing in this area. So please work in this area. Those are the exciting area, particularly for the engineers. Thank you.
Okay. Any other questions? Please feel free. This is a good opportunity to enhance your knowledge. Please ask or check if there's anything check your own existing knowledge as well. So please ask any more questions, please.
Hello.
So I guess people are out of questions and they might be reflecting on your lecture. And I'm sure that because this would be hosted online, so they will go back. Oh, okay. So we have Danish and Asta as well.
He had a question. He had a question.
Yeah, please go ahead.
Hello. Am I audible? Hello.
Yeah, you are audible.
Sir, my question as I posted on the chat is, will there not be more side effects of the spleen vagal patch, given just how extensive the vagus nerve is in distribution? And would that in turn not create more problems to the patient than good?
That's a very good question. I'll be honest with you, I've not looked at the data in detail, but it has been shown and proved to be of great benefit to patients. I need to look at the actual data on this, but it's a very, very good question in terms of the effects on the rest of the body. But I think when you consider that patients, with inflammatory arthritis are both stressed biologically and mentally as well, the benefits are quite good in this patient group. So valid question, but I think they obviously have tested for this. The Dutch group has tested for this and found it to be of great benefit in most of the patients they've tried it on without major side effects.
Thank you, sir.
I think Asta, if you're speaking, you are on mute.
Yes, sir. Hello, sir. So my question is that once rheumatoid arthritis is being detected, what are the precautionary cautions one need to take? Like once a doctor told my mother that not to bow down suddenly and to not to sit below a certain height. What are the other precautions one should take except from the diet also? Like,
I don't think there's actually precautions. What I advise my patients is to keep active. And whether it's sitting down on the floor or doing any certain movements, I think the key is activity. So I usually recommend to my patients yoga, Tai Chi, or Pilates to keep them active and keep them busy and keep their joints moving. Certainly something we aim to do in treating patients with inflammatory arthritis is to keep them active and as normal as possible. And movement is the key. So any obviously sitting down for long periods may be a problem, but there are ways of dealing with that. So I think our aim is to enable patients, not disable them. So I would advise that if your mum hasn't done already, but to consider taking up yoga, that will be a benefit in terms of keeping her moving, keeping her nimble, and keeping her able to do her day-to-day jobs. And obviously the endorphin effect of that will have a beneficial effect on the rest of the body as well, in addition to the existing medication she's taking. Obviously, you've already alluded to diet, which has been shown to be beneficial to a degree, provided you're taking the right diet. And obviously, there are various other measures that can be done. So, for example, patients find having a shower in the morning with either hot or cold water is beneficial. I've had a few who've had cold. Majority have found having a warm shower has been very beneficial in getting their joints moving in the morning. Through the day, if there's a problem, you can wash your hands in warm water to actually keep that effect going on. Patients sometimes will, make a regular hot drink and have that held in their hand. That again, heat has that anti-inflammatory effect as well. So a number of measures you can undertake to actually keep active. Sometimes patients use anti-inflammatory gel on their hands in the day as well to reduce the pain and symptoms of the pain. But the key is obviously to actually get the disease into some degree of remission so that they're not stiff for any more than 30 minutes or less than 30 minutes, preferably, with less problems overnight, and they have a good night's sleep, and they can remain active and productive during a normal day.
Okay, thank you, sir.
Does that help? Yes? Okay. Good. Vijay?
Yes, sir.
You have another question? Yes, sir. More?
Yes, sir. So actually, if a female get a female diagnosed with RA during their initial phase of life, so how RA impact their pregnancy during pregnancy? Like if someone is diagnosed with RA and she start her life, and how RA affect their pregnancy life during pregnancy?
So,
it is progressive or not?
So for the most part, actually, we find most patients actually go to remission because in the pregnancy, the body's natural steroids will be released, and that has a modulating effect on the disease process. We find more often than not that we don't really have to give them any medication, so the disease actually gets better, and that effect can last up to 3 to 6 months after delivery of the baby. So actually, pregnancy has a positive effect on the disease process itself.
Yeah. No, thanks, Dr. Nav. I mean, it's been absolutely a pleasure listening to you. And I think last week, few weeks of interaction and I think there's a lot of preparation that you kind of put in, especially to give this a Indian context, right? And I could see that you've looked at it from research from the epidemiology standpoint, or the nutrition, and then some bit of the history. So I think it was a wonderful compilation, and I think it's very good seeding that all the participants and it including me as well, though I had some of this information or access to the information prior to this session, but I think you filled in a lot of the talk and some of those insightful experiences from your journey, and I think very, very pointed, specific responses. So thanks a lot for that. I'm sure that this is today is the first session. We have a week-long set of sessions which are arranged, and I'm sure there will be a lot of questions as to you. Maybe you'll get them one-on-one, or people will reach out to it in small groups. So I'm very sure about that. And I think thank you so much for your time and patiently answering. We look forward to your continued support, and I think also bringing in other ecosystem stakeholders. I'm sure Dr. Dheeraj has a lot of interesting assignments and project work. So all the participants will need your guidance, and look forward to the next 2 months of exciting journey on this Eduthon. So, and I think as I speak, Yash has a question or has a comment. Over to you, Yash.
सर बेसिकली मैं इंजीनियरिंग कर रहा हूँ, तो हो सकता है कि मेरा जो क्वेश्चन हो थोड़ा ऐसा गंदा सा हो आपके लिए। सर बेसिकली हम जब बात कर रहे हैं आर्थराइटिस के, तो इसमें पेन डेवलप हो रहा है बोन्स के बीच में, मतलब बोन्स में, जॉइंट्स में। तो वहाँ पे जो पेन गेट कंट्रोल थ्योरी होती है, जिसमें नर्व्स जो होती है स्मॉल साइज के, मतलब थिन साइज की होती है, वो ओवरकम कर देती है हमारी लार्ज नर्व को, तो वो क्यों नहीं हो पाता है?
Right. So the question essentially is in relation to neurogenic aspect of rheumatoid arthritis, essentially, and how. So what you have essentially is that when you have any damage to any tissue, whether it's your skin or your joints or any part of your body, a signal is sent through the nerve through to your brain, and the key is how that interaction takes place between your brain and what's going on. So you're aware of, obviously, various things where you see people who, for example, will fry things using their hands and feel little pain. And so, in terms of arthritis, it's a spectrum and how people react to that disease process. And that may be down to their own sort of psychological, their own sort of mental makeup as well. So in terms of the nerve damage itself, that can heal, can get better, but it's a combination of the factors that are going on. So stress, smoking, all these things will make matters worse, as well as the inflammation. The key is to reduce the inflammation. There will be some residual joint damage that's taken place, but hopefully over time that will heal, provided the inflammation is less. And that, combined with appropriate painkillers such as paracetamol or anti-inflammatories or anti-inflammatory gel, will have the desired effect, as well as appropriate exercises as well to try and stretch out the joint and return to function. So what you have problems also is that when the patient gets the arthritis, it affects the normal functioning of that particular area. So the key is, with appropriate input from occupational therapy and physiotherapy, is that function can be returned to some degree of normality, and that will also reduce the pain as well. So part of the problems with pain are due to damage and loss of function, and also the patient's perception of pain as well. So by modulating those three factors, we could potentially lead to an improvement in the patient's pain and well-being and outcome.